Welcome, everyone, to the Center for Global Development virtual platform. I'm Amanda Glassman. I'm the Executive Vice President and a Senior Fellow that works on global health policy here at the center. Today, I'm really pleased to host an event that looks at the issues surrounding access to vaccines and one intervention, some evidence on a new intervention in northern Nigeria, small cash transfers in exchange for full vaccination for age for children. As we know, progress on childhood vaccination has stagnated or reversed due to COVID-19, but even before COVID-19, estimates aggregated across all Gavi-supported countries show modest gains in vaccine coverage between 2015 and 2018, if we look at WHO UNICEF data. Coverage for some really critical vaccines like measles has been about the same over many years. And even DTP3 or pentavalent 3 coverage increased only very modestly. And if we look at a country like Nigeria, obviously they've made huge gains overall in coverage of vaccine over the past couple of years, but there's been enormous and durable inequity between states, with some of the northern states having quite stagnant coverage for many, many years. If we look, even if we look overall, despite the gains, we're still at about half the population fully immunized against pneumococcal conjugate vaccine, for example. So what's going on there? Part of the answer obviously is supply, meaning what's happening in terms of the clinical provision of care and hours of clinics, how accessible clinics are. But another piece of it has to do with what economists call the demand side, families themselves, because as much as preventive care is great and has an intrinsic value, if you're a very poor family, accessing preventive care is also very costly. It's the transport, it's the time that you're not able to work. And the childhood immunization schedule is fairly demanding. You have to go fairly regularly to get the vaccine. And it's not something, obviously, that can be easily delivered in the home, although there are campaigns, of course. So one way that countries and their development partners have looked at this issue is to think about what are the ways that we can decrease those barriers to access for something that is so important like childhood immunization. And one of those instruments has been cash transfers. Now, cash transfers can be used as a safety net. They can be used simply to increase consumption of healthy foods, and they've been very well evaluated for those uses. And in general have had pretty positive impacts. There's another kind of cash transfer, the conditional cash transfer, that says you get some of the funding against use of certain kinds of services. So this is a model that's been tried all over Latin America, all over sub-Saharan Africa now. This particular intervention that we're looking at is now focusing on a conditional cash transfer for a specific intervention, full immunization for age. I would say cash transfers aren't new for Nigeria either. There has been a program of cash transfers to look at utilization of maternity services, and this year, two impact evaluations were released by Edward Okeke at RAND and his collaborators that found, that the cash transfer for maternity care for birth has led to an incredible increase in facility deliveries and improvements in quality of care. And other authors, Onwuchekwe and others, also find that those transfers were particularly cost effective. And now we have some new evidence that looks at cash transfers for childhood immunization. This is a program that has been run by New Incentives. Now, I should disclose that I am on the board of New Incentives, but I have worked on the issue of cash transfers for many years, starting at the Inter-American Development Bank, where I worked on the big conditional cash transfers in Latin America, Oportunidades, and Colombia's Familias en Acción program. So I have a long interest in this area. These things are not a silver bullet, but they can work in certain contexts with good design. So we're going to hear a little bit about what this program looks like, and we're going to start with Dr. Shaimu Kabir, who will talk about sort of the problem statement. What is it that this program was intending to solve? I'll let her introduce herself, but she is the program manager of the State Emergency Routine Immunization Coordination Center in Katsina State. Are you there, Dr. Kabir? Hello, go ahead. So we can't hear you. Can you check your microphone? Still nothing. I'm really sorry. Can you, yes.
Okay, yeah, so good afternoon, everyone, once again. So I will be talking about
Can you put your microphone closer to your mouth? Sorry. It wouldn't be a Zoom conference if we didn't have technical difficulties. So thanks for your patience, everyone. We'll get it done.
so I will be
Great.
talking about the problem vaccination in Nigeria. So I will start briefly by giving the overview of immunization in Nigeria. Nigeria launched standard program of immunization in the year 1979. That is about 5 years after the World Health Organization has launched the program. This program has been revised in 1984 in Nigeria, and it was later renamed as the National Program on Immunization. That is for the Nigerian government to demonstrate ownership of the program. The optimum level of success recorded by the EPI was in early 1990s, with the country achieving a universal childhood immunization coverage of 81.5%. But since that period of success, Nigeria has witnessed gradual but persistent reduction in immunization coverage. By 1996, the national data shows that less than 30% of coverage for all antigens, and this um, decreased to 12.9% in the year 2003. In 2018, the National Demographic Health Survey shows that only 31% of children aged 12 to 23 months has received all basic vaccinations, while only 21% has received all age-appropriate vaccination. So there are various age groups that were targeted for immunization in Nigeria. For the routine immunization, children 0 to 15 months of age are being targeted to receive routine immunization. Then children 0 to 59 months were usually targeted during campaigns. The women of childbearing age were being targeted for the TD vaccine, and those at risk population are being targeted when we are conducting any campaigns for an outbreak response. And we have yellow fever vaccination for the international travelers. And for routine immunization, it is expected that a child will have 6 visits from birth to 15 months to receive um, immunization on BCG, hepatitis, OPV, and pentavalent measles, meningitis, yellow fever. So now this
Dr.
is just
Kabir, can
a
I ask you
brief.
to put your hands down just because it's not totally clear coming through. Thanks. Sorry for the interruption. Go ahead.
Okay, so
Perfect.
there are various strategies that are being used for immunization in Nigeria. We have the fixed post sessions where is being conducted at the health facilities. We have the outreaches and the mobile posts that are being used for routine immunization and during campaigns. So this is just the brief overview. Now looking at the challenges for immunization in Nigeria, there are enormous challenges, but the government, with support from other partners, is trying to deal with these challenges. That we have issues related to leadership and coordinations, but with the establishment and implementation of PHC under War Room strategy and the establishment of National Emergency Routine Immunization Coordination Center at the national level and the state emergency routine immunization coordination center at the state and the LGA, we have the local government emergency. So this has helped a lot in solving the issues of governance and coordination respectively. respectively. We have issues related to poor knowledge and benefit of immunization, issues around access to services, rumors and traditional and religious beliefs has hindered demand for immunization. But there are some community engagement strategies that are being implemented, like the new community engagement strategies that is being implemented in the country to assess to improve the demand for the routine immunization. And we have other interventions that have been adopted, like the conditional cash transfers that is being implemented by the new incentive, All Babies Are Equal. So other challenges of immunization in Nigeria um, around challenges, including those related to human resource for health, with the related gaps such as poor funding for health, lack of motivation, especially to work in remote communities, need for capacity building and enhanced accountability. Other issues are around the data management, data reporting. We have gaps such as data falsification issues, with huge discrepancies being seen with in administrative and survey data. We have other issues that are around supply chain management, with the gaps related to inadequate cold chain equipment. Though the Gavi is now supporting the country to provide SDDs, at least one for each of the senatorial wards in the country, but still we have issues related to inadequate other passive culture equipment. We have been seeing stock out at the service delivery points and high vaccine wastages. But still, even though we have these huge challenges, we have had some success stories, such as the in governance reform, introduction of new vaccines in the country, the polio-free certification, we have ability of the country to begin the COVID-19 vaccination, and the improvement in percentage of children aged 12 to 23 months who receive all basic vaccination. We have seen an increase from 23% in 2008 to 31% in 2018. And while we are doing our best to deal with these challenges that are surrounding our immunization in Nigeria, now we had the COVID-19. We have the COVID-19 that started in 2019 and got into Nigeria in 2020. And we are aware that COVID-19 took a huge toll on even the best health system in the world, and it exposed the weaknesses in the other health system. Nigeria was not left out of our health system, was overwhelmed. The economy of the Nigeria government was affected by the preventive measures such as the lockdowns that led to Nigeria going to one of its worst recession in that's last year, 2020. And the health sector and as well the immunization services were not left out. So access to common health services were affected by fear of, and many have died of ailments that were not related to COVID-19 due to inability of access to services. So both the demand and supply side of routine of immunization were initially affected. That is during the onset of this pandemic, but things are normalizing now. In terms of supply, we have seen during when we had the lockdown, there were stock out of vaccines, but um, that has delayed the country that there's a delay of transporting the vaccines into the country. But now we have all the antigens now available, and caregivers are now coming to health facilities to access the services. The government and partners tried their best to manage the COVID-19 pandemic by developing policies, protocols, and providing preventive tools. And at this point, I would like to commend all the partners that have been supporting the Nigerian government, the Katsina state in particular, and the new incentive of babies are equals are one of our partners that supported the state in fighting this COVID-19 pandemic by providing IPC materials to the health facilities where they are being operated. So finally, as I've mentioned, immunization in Nigeria has had its good days, but there still remains demand and supply side challenges related to vaccine access, supply chain management, human resources for health, and data management. These demand and supply side challenges were worsened by the COVID-19 pandemic. However, government and partners have been working to address these challenges with some successes achieved, but there still remain some work to be done to reach our immunization coverage. I would want to use this opportunity to of speaking at this webinar to thank our partners that have been supporting us to improve routine immunization in Nigeria and in Katsina State in particular, and the request for their continued support so that together we can achieve our coverage target, reduce deaths due to vaccine preventable diseases, and save lives of children in Nigeria. Thank you very much. Thank you for listening.
Thank you so much, Dr. Kabir. And I know, sorry about the quality of the audio, but I think I heard your points loud and clear about how both supply and demand issues are at play in getting vaccination rates up, especially in this COVID-19 period. So let's now turn to Sveta Janumpally, who is the founder and Chief Executive Officer of New Incentives, that has been working on this conditional cash transfer program together with her Nigerian colleagues. So go ahead, Sveta.
Great, thanks Amanda and Dr. Kabir. I'll just wait for my slides to start. Hi again, everyone. My name is Sveta Janumpally, and I'm the founder and CEO of New Incentives. Next slide, please. I'd like to start by telling you a little bit about where New Incentives operates. On this slide, you can see a map of Nigeria. The red square at the top shows the 3 states where New Incentives is operating, called Katsina, Jigawa, and Zamfara. These 3 states are located in the Northwest region. This region has the highest rates of under 5 mortality, as well as the lowest immunization rates in the country. The region experiences some major challenges. Many areas are remote and they are difficult to reach by road, and there are high rates of poverty and insecurity. Due to large investments by the government and vaccination partners over the past decade, immunization services are readily available and accessible and are provided for free by the government. So you might be surprised that there are actually over 3,000 clinics offering routine immunization services in these 3 states alone. Yet at the same time, less than 1/4 of the infants get fully immunized. Low immunization coverage in this region is therefore not only a problem of access to vaccinations, but also demand for vaccinations. Next slide, please. Conditional cash transfer programs, or CCTs, are one potential solution. As Amanda mentioned earlier, these programs give money to low-income households in return for fulfilling specific behavioral conditions. These conditions might include children's school attendance, up-to-date vaccinations, or regular visits to a healthcare facility. We were inspired by this growing body of evidence behind conditional cash transfers and saw an opportunity to apply the CCT model to complement government and partner efforts to increase immunization rates in Northwest Nigeria to help address some of the demand side problems affecting the region. New Incentives CCT program has 3 primary components. I will walk you through each one. The first component of our CCT program is raising awareness about the importance of vaccinations and the existence of the incentives program. This is very important because people need to know the incentives exist in order for them to influence behavior. We raise awareness by closely collaborating with community and traditional leaders and to spread the word and gain buy-in from key influencers in communities. In this slide, you can see an awareness card our community partners distribute. This card was developed based on feedback from participants to make sure we maximize understanding and suitability with local practices. If you could go to slide 5, please. The next component of new incentives program is monitoring the vaccine supply chain to ensure that whatever demand is created can actually be met by the supply chain. Here you can see an illustration of caregivers waiting to get their infants vaccinated. Sometimes vaccines can be out of stock, or maybe they run out during an immunization session. We closely monitor these issues and engage with government partners and clinics to remove bottlenecks in the supply chain. Next slide. The third component of our program, the heart of it, is the conditional cash transfers themselves. The conditional cash transfers have 2 key parts. The first is that the caregiver needs to meet the condition in order to be eligible for the transfer. The second part is dispersing the cash transfer. Eligible caregivers and mothers can earn up to 4,000 Naira, or approximately $11 US, over the course of 5 clinic visits. As you can see from this image, the transfers are given over the first year of an infant's life as they go through Nigeria's routine immunization schedule. The clinics that provide vaccinations are often located in rural areas and that do not have internet, and most of our caregivers do not have mobile devices. Our team of over 120 field officers go to clinics and only disperse the incentives to caregivers of infants who have received the required vaccinations. Next slide. Our approach to program delivery is grounded in 2 core values: accountability and verification. This slide shows a little glimpse of some of our program dashboards. Our team has developed cross-cutting capabilities that allow us to carry out all field activities in a very data-driven, verifiable manner. We have detailed expenditure, performance, and fraud monitoring policies and systems to assess fidelity to conditional cash transfer operational protocols in each and every step. To date, we have dispersed over 1 million conditional cash transfers. And we will be growing over 3x to enroll over 600,000 infants and distribute over 2.7 million conditional cash transfers over the next 3 years. Next slide. It's important to understand that new incentives program is layered on top of existing government immunization services. We do not provide immunizations. Our program is complementary to the substantial efforts the government and immunization partners are making. We partner hand in hand with state governments and local governing structures and contribute to initiatives to strengthen routine immunization services. We are really excited to continue deepening these relationships as we scale up. Thank you very much, everyone. This concludes the overview of new incentives program, and handing over back to Amanda.
Thanks, Sveta. And now let's talk about what all this has generated in terms of immunization coverage. With that, I'll turn it over to Allison Connor from IDinsight and Dr. Segun Oguntoyimbo. Actually, both of them are doctors. So please go ahead. Thank you.
Thank you, Amanda. As I share my screen here, I just want to start by first thanking CGD for hosting this webinar and for inviting Hanovia Limited and IDinsight to participate. We are absolutely thrilled to be here today, not only to present these exciting results, but also because the ecosystem in which this evaluation was designed and conducted was just so unique. The policymakers, funder, and implementer new incentives were each so committed to acting on the evidence that we produced. And all of them were at the table with us throughout this process to ensure that the evaluation was well positioned to answer their most pressing questions. This type of ecosystem undoubtedly shortened the distance between the research and more children receiving life-saving vaccines. And I really hope that this model can be replicated in the future. So let me turn it over first to my co-principal investigator, Mr. Segun Oguntoyimbo, who will now introduce the evaluation.
You're on mute.
Yeah, thank you, Allison, and thank you, Amanda. Hanovia Limited and IDinsight had the honor of collaborating on the impact evaluation of new incentives all babies are equal conditional cash transfers for routine immunization program, which measured the impact of the program on the uptake of childhood immunization. This evaluation was conducted to inform GiveWell's decisions about future funding for new incentives, as well as policy decisions in Nigeria on how best to improve immunization uptake in these regions. We used a cluster randomized control trial design, which is the most rigorous evaluation design. It allows us to say with the greatest certainty that the differences we see between the treatment and control arms can be attributed to the program. The evaluation surveyed 12 to 16-month-old children living in the catchment areas of the treatment and control clinics. It took place from July 2017 to February 2020 and included a baseline and an endline survey. Next slide, please, Alison. The evaluation took place in 3 states of Northwest Nigeria, namely Zamfara State, Katsina State, and Jigawa State. We started by selecting 167 health facilities to be included in the study. New incentives, All Babies Are Equal program screened these clinics according to their operational criteria. These included security, availability of consistent routine immunization services, how far it was from a town, and number of clinic staff. Since we were concerned about caregivers from controlled areas going to treatment clinics if they knew about the incentive, we also picked clinics that were at least 17 kilometers apart. This map shows the location of all the study clinics. Next one, please, Alison. For sampling households, we used a method called compact segment sampling. This involved dividing every settlement in each study catchment area into segments of approximately a quarter of the population.
Shagun?
I can
Yeah.
just jump in for Shagun while his connection is refreshing. So as Shagun was saying, our sampling method was compact segment sampling. We divided each settlement of every study catchment area into approximately 25% of the population and randomly selected one of those segments to fully survey. So we first surveyed all households in those segments to identify our eligible 12 to 16-month-olds. We then conducted a routine immunization survey with caregivers who had a 12 to 16-month-old. And that survey was used to collect self-reported data on immunization, caregiver attitudes and practices toward immunization, and other health-seeking behaviors. We then went to 160 of the study clinics to look at administrative data to verify this self-reported data. So what did we find? Okay, first, we found that even without the NAABE program, existing efforts to improve immunization coverage were having impact. So many of the efforts that Dr. Kabir mentioned. Among children living in non-program catchment areas, we actually found an increase in immunization coverage between our baseline survey in 2017 and our endline survey 2.5 years later. You can see on this graph, the light blue bars represent immunization coverage at baseline and the dark blue bars represent coverage at endline. So we saw increases of 18 to 36 percentage points over this time frame. We include BCG scars here because that is the more objective confirmation of immunization than self-report can be, though of course it too may be imperfect. So what did we find in program catchment areas? New incentives, all babies are equal, conditional cash transfer for routine immunization program increased immunization coverage in addition to these increases that were already achieved in non-program areas. So in this graph, the gray bars show coverage among children in the catchment areas of the non-program clinics, and the blue bars show coverage among children in the catchment areas of the new incentives program clinics. You can see that the program increased BCG coverage by 16 percentage points, coverage of the first dose of pentavalent vaccine by 21 percentage points, and coverage of measles vaccine by 14 percentage points. All of these increases were statistically significant, and ultimately, this meant that the new incentives, All Babies Are Equal program boosted immunization coverage in the study areas to around 75 to 83%. Now, we also looked at the program's impact on whether a child was fully immunized. In this case, the definition of fully immunized was if the caregiver reported that the child had received BCG, all 3 doses of pentavalent vaccine, and measles vaccine. The program more than doubled the percentage of children who were fully immunized, a 27 percentage point increase. In addition to coverage, we looked at timeliness of immunization. So that is the age at which children received the vaccine compared to the recommended age. Now, as many of you know, this is important because if the child receives the immunization long before the recommended age, the vaccines might not work as well. If the child receives it long after, she spends part of her life without the protection of the vaccine. So we looked at whether the new incentives, All Babies Are Equal program improved the percentage of children who received incentivized vaccines within 2 weeks of the recommended age. And while we did not find an impact on the timeliness of the BCG vaccine, which is given at birth, we did find a 9 percentage point increase, in the timeliness of the first dose of pentavalent vaccine and a very large 39 percentage point increase in timeliness of the measles vaccine at 9 months. Now, we also looked at indirect impacts that the program might have had. And we found positive impacts on vaccines that are not directly incentivized by the new incentives program. So that is, we found a statistically significantly higher percentage of caregivers in program areas who reported that their child had received yellow fever vaccine, IPV, hepatitis B vaccine, and at least 4 doses of oral polio vaccine. We also found a higher percentage of children who had used a health clinic for the first time in program areas. Now, we did not find a statistically significant increase in at least 1 dose of oral polio vaccine or vitamin A coverage, and this may be because the first dose of OPV is fairly common as a result of campaigns, and vitamin A is typically given at 6 months in Nigeria, which does not match the timing of any of the incentivized vaccines. Now, we also found that there were small but statistically significant increases in caregiver knowledge about immunizations. So the blue circles on the left side of this slide show that the percentage of caregivers in the control group who knew the age of first injectable vaccine, at what age a child should receive the measles vaccine, and how many times a child should be vaccinated before 1 year of age. The yellow circles on the right side of the slide represent these same percentages among caregivers in program areas. And you can see knowledge was about 5 to 14 percentage points higher among caregivers in program areas, although there is still a lot of progress to be made here overall. All of these increases were statistically significant. Now, finally, we looked at vaccine stockouts. One component of the new incentives program, as Sweta mentioned, was stock checks. So again, new incentives staff members check vaccine supply on routine immunization days and flag to routine immunization staff if stock is low. We asked clinic staff about the frequency of vaccine stockouts in the 12 months prior to endline. We found that program clinics were more likely to report either no vaccine stockouts or rare vaccine stockouts. So this underscores that the program not only increased immunization coverage, but also improved vaccine stock. So to quickly recap, new incentives, all babies are equals, conditional cash transfer for routine immunization program, first supplemented existing immunization efforts, 2, increased coverage of incentivized vaccines, 3, improved timeliness of vaccination for pentavalent and measles vaccine, 4, had positive externalities on coverage of non-incentivized vaccines and healthcare utilization, 5, improved caregiver knowledge and attitudes about vaccines, and 6, reduced vaccine stockouts. So this summarizes the evaluation findings. Thank you so much for the opportunity to share these with you. Back to you, Amanda.
Thank you, Allison, and Shagun, apologies. Do you have anything to add here at the end quickly, since you were knocked out by connectivity for a little bit?
Thanks, Amanda. I don't have any other thing to add, and apologies for getting locked out.
No problem. We'll bring you back on the discussion. Okay, so now we'd like to turn to a sort of panel kind of discussion, and we'll kick off with GiveWell, which is the funder of both new incentives, all babies are equal, as well as the commissioner of the evaluation. And I think that's a really interesting model, because many times people wrap the evaluation of an intervention into the grant that you give to the organization itself. In this case, the funder commissions the evaluation separately, which should be good for issues like independence. But it also means too that it's sort of a built-in client. They were going to take a decision based on the findings of this evaluation around funding. So maybe I'll ask Buddy Shah of GiveWell. Of course, you should also disclose, like all of us, you also had some affiliation with the evaluator, but during the process of the evaluation. I'll let you explain all of that, but I'll turn it over to you, Buddy. Thanks.
Yeah, great. Thanks so much, Amanda, and thanks for the excellent presentations, Dr. Kabir and Segun and Allison. So just in terms of disclosures, I was previously the CEO and co-founder at IDinsight when this project launched, and for the last 8 months or so, I've been the managing director at GiveWell, which, as Amanda mentioned, funded both new incentives on the implementation and program development side, as well as IDinsight's randomized trial and Hanovia Limited's randomized trial of the program. So I think a couple things that I would just mention about the funding setup in this case. I think that there's this initial period of funding Sweta's work and new incentives, which was somewhat flexible long-term funding in order to really figure out what's the most cost-effective program that they could run. And in GiveWell's internal framework, what we look for are programs that can essentially beat our threshold of roughly $3,000 to $5,000 US per life saved. And so the things that we fund are anti-malarial bed nets, seasonal malaria chemo prevention, vitamin A supplementation. And Sveta really came to us and said, look, I think that we can go to the literature and try to identify programs and build up an organization that can actually meet that level of cost effectiveness or potentially even beat it. And so the first part of the story, I think, is just having this clarity between both the funder and the implementer on what does success actually look like, and how can we support a talented and an entrepreneurial organization to try to really beat a very high bar of effectiveness. So that's kind of part one of the story, and that's a long journey that maybe Sveta can comment on. And then the second is, once there's enough clarity on what does success look like and sufficient funding to try to develop and pivot a program in order to meet that level of cost effectiveness, at some point you want to have a kind of clear test of, is this program working sufficiently well enough such that it's better than our other investments at saving lives. And so that's where the IDinsight piece comes in, of saying, let's design a rigorous impact evaluation, which before we even roll it out, we have clarity on, is this evaluation going to help us answer the question of whether new incentives is as or more cost effective than GiveWell's other grant making. And so there's something somewhat unique in the design of the evaluation, such that the pre-analysis plan, the powering of the study was all geared around, are we going to be able to tell whether this program is more cost effective than GiveWell's other opportunities and therefore should absorb a lot of funding. And then I think the third element, which is somewhat interesting, is in addition to the actual evaluation, the randomized controlled trial, one of the things that evaluators can bring that's of great value is just ongoing data support in order to inform an implementer's operation so that it can continually improve. And so that was something also that GiveWell helped to support in the partnership between IDinsight and New Incentives, to have that kind of ongoing data used to inform their own programmatic operations. And so, I think the end result of this was that ultimately New Incentives met an extremely high bar for cost effectiveness, better than $3,000 per death averted. And if you look at the global literature on best buys in global health, this is, at least in GiveWell's estimation, about as good as it gets. And so now the question is, GiveWell can help scale it a certain amount. We recommended a $17 million scale-up grant for New Incentives over the coming years. But clearly, the big game is also in working with government partners in Nigeria, as well as other partners like the Gates Foundation and the broader Nigerian public health community around what implications does this have for other states in Nigeria, and to what extent is this something that over time can become part of state or national policy? And so those are things that we're very eager to learn from other partners that have deep experience with those things.
Excellent. Thanks a lot, buddy. Now let's turn to Dr. Yusufari, who has worked in the health sector in Nigeria for many, many years, and was just mentioning that he had worked on a previous evaluation of an initiative on primary health care with Segun in an earlier role. But can you reflect a little bit about the significance of this trial and this effort, and the effort to get all kids in Nigeria fully immunized? Where does it fit? How do you think about these results and their implications?
Thank you, Amanda and team. And first we have to look at the context of routine immunization in Nigeria. And Shema'u made a very good narrative around that. But two key things we need to observe about routine immunization in Nigeria is that Nigeria still accounts for a quarter of global unimmunized kids. So Nigeria harbors a disproportionate number of unimmunized kids. But also there is huge regional variation in immunization coverage in Nigeria. If you look at the heat map for immunization coverage in Nigeria, you will see regional variation north-south. You also see rural-urban variation. You see also variations within the income quantiles, and even educational background. So Nigeria is such a complex environment. Second is also that improved in Nigeria, and that's one other key issue around Nigeria. So it creates that problem for managing vaccine preventable diseases, but also issues around the introduction of new or underserved, underutilized vaccines. So for me, this is what has happened in the last 30 years. So for us is to say, what are the new, or rather the unconventional and non-traditional method that we can adopt? Meaning, are there innovations that we can really put in place? And so the new incentive program is one of those strong innovations that have really been implemented, and the evidence are out there for everyone to see. The challenges for immunization are really unique in their context in Nigeria. The primary healthcare system is weak, is vertical and fragmented. There are huge demand and supply side issues. Some of them have already been mentioned, but there's also huge problems with performance of the PHC program. And that's why we have the high morbidity and even mortality within the system. But the incentive program that has been introduced, there are evidence around out there in the field that has really reinforced the need for incentives and how incentives can become a tool to address chronic underperformance. In the 3 states that have just been mentioned, I recall I worked in that state like 10 years ago. When our program ended in 2013, these same states were at this level. So meaning that 10 years thereafter, no significant improvement has happened, or coverage went down, and now we have to really restart the system all over. There are also multiplier effect of the incentive package that have been put in place. And therefore, in our effort to rethink how we could implement the incentive package, look at how do we implement this within the context of either continuum of care approach, or how do we look at how this is embedded within broader PHC system strengthening. And there are also lessons learned. You will recall that you all know there are other multiple incentives programs across the country. And then the partners and donors around are also implementing one form of incentive or the other. I give you an example with the Gates Foundation. We signed memorandum of understanding with states, and we will fund some part of their routine immunization program on the condition they also fund the program. So we put money into a basket contingent on government also putting their contributions. Now this basket is now used to implement broader immunization and PHC work plan. At the federal level, we are also working with government that if government meets their vaccine co-financing commitment, we will give an incentive of about $15 million annually. And in the last 2 years, government has not really defaulted in meeting their vaccine procurement co-financing commitment. So there are lessons to learn in incentive packages, but we have to also look at the realities of implementation of the program. Huge demand side issues that have not been addressed, huge supply side components that also need to be addressed. But there are huge opportunities in the horizon. The lessons learned and evidence that is available for me is a much bigger incentive for government to say yes, partners to also rally around and look at how effectively can we put incentives and where are we going to put that incentive? Where are the levers of change that we can put incentive package? And therefore, the key question is, if we're going to put incentive, how can it sustain coverage, and how can it address equity and also gender issues? There are huge gender dimensions to this problem that are silent out there. For example, in demand side, in the work that we do and the current work that we are doing, there are huge demand side. Mothers have to get permissions from their husbands before they take their babies for immunization. And so addressing those barriers are very critical. In the supply side, quality of care is critical. The client satisfaction, availability of vaccine, timely availability of vaccine are all very critical for services for people to access the care. On the government side, the implementation of the basic healthcare provision fund provide an opportunity for both partners and government to work. As you all know, government is dedicating 1% of its consolidated revenue to revamp and finance PHC. And that money is going directly to health facilities to deliver services. So as health facilities begin to redesign their service delivery, that's a huge incentive for them to really reach every child and every mother. And therefore, incentive packages need to look at where will be the levers of change. And in doing that, look at the design of service delivery, look at what package of care is available, and the design of how demand will be generated and how performance management can be implemented. And of course, in our new normal, we are also saddled with COVID, the reality of COVID. The reality of COVID today is such that a lot of resources on both government and partner sides have been repurposed for COVID. And with that, and most of the attention also of key healthcare workers and their managers is now also shifted to address the pandemic. So how do we look at maintaining essential services? Routine immunization, very, very critical. but also other critical PHC services. And therefore, the imperative of prioritizing essential service delivery, prioritizing PHC services, and also redesign of the delivery mechanism. The world has changed with COVID, and we don't know what the next pandemic is going to be, but we have to start planning for that. And for us to plan for that, we have to have high coverages, because only having high coverages will really guarantee and minimize the effect of other pandemics. And finally, as we rethink incentive, we really have to put at the core coverage, equity, and addressing those gender issues. Second, we have to look at where are the levers of change, and when will incentive make sense. Third, we have to look at sustainability. One key issues that we also need to look at is sustainability of incentive package. We've not seen the positive government buy-in, and it's essentially donor-driven. And so we have to rethink how much can we use that to really leverage or incentivize government buy-in in such a way that we could have sustainable sustainable incentives, but also sustainable funding of immunization and PHC programs. So I'll pause here, and then in the Q&A, I can answer other questions. Over to you, Amanda.
Thank you, Yusuf. So let me step back a little bit and reflect on the Gavi Alliance, for example, the Vaccine Alliance, right, which is working in the lowest income countries. Of course, I think that Nigeria is now middle income, at least according to at least prior to COVID, but still in a kind of transition phase with Gavi, still participating in Gavi, and the Gavi board has identified equity as a major issue that they need to address in the coming years. And as you say, there is a clear supply side agenda on this. I think we're all aware that just buying vaccine is not enough. It's about delivery. And that countries have gotten very good at delivery in areas where people were sort of ready to take vaccines up, and where, levels of poverty were less. So as we think about, equity strategies in immunization, on the demand side, of course, there's an information intervention. I think what's interesting about the new incentives, All Babies Are Equal intervention, is that it includes awareness raising as well. And you can see how low awareness is, or knowledge about when vaccines are needed. I think it was like 11% of mothers were saying that they knew about when the timing of measles is needed, for example. And the baselines, obviously, in some of these states is very low, 25% fully immunized in the case of. But this is not exceptional. I would also say, like, working in Latin America, poor municipalities had about half the full immunization coverage of high-income municipalities. It's like a very common phenomenon. It's obviously not just about immunization. It's about inequalities in spending, the baseline characteristics of the populations that live in poor areas of countries. I mean, I just wonder whether this should be more prominent in the discussion about how to deal with vaccine inequity. I mean, I know that Gavi, for example, put out a document on demand side interventions, and I'm not sure that this was included among them. So I guess my question to the panelists is, like, looking at the international support for vaccine equity, and also considering the fact that COVID-19 requires some attention to generating demand, how would you see this kind of intervention playing? And maybe I'll start with Sveta, and then ask Yusuf and Dr. Kabir to come in. Go ahead, Sveta.
So the equity gap is really what we're set out to solve. So both within differences due to gender, but also due to location. So some populations might be more migratory or might live farther away from clinic services. And so a lot of our awareness and efforts addresses some of these gaps around cultural norms against immunization, local practices that might prohibit women from leaving their homes in the first weeks after birth, and trying to address some of these issues that cause those equity gaps. So I think as COVID-19 has, really reduced routine immunization coverage and reduced the likelihood that people are coming for immunization services, we need to work harder to make sure we understand what population we're reaching and use data to adjust our programmatic strategies to make sure that the totality of a population served by a clinic is actually reached and participating in vaccination services.
Maybe Dr. Kabir, do you have any thoughts on this issue, sort of the role of the demand side vis-a-vis all the work, of course, that you're doing to strengthen clinics so that they can operate vaccination programs?
Oh, thank you very much. There are so many interventions and strategies that are being used to improve the demand side of immunization. Nigeria, we already have established traditional system, which was used by the polio eradication program to improve demand for the unacceptability of polio. So we are still using the same structure to create demand for routine immunization, looking at the already established structure. Then the National Primary Healthcare Agency has now developed another demand community involvement strategy, where we are going to be using the community volunteers, the CHIPS agents, to create more demand for immunization services at the lower level. Then they included harmonization meetings where the community leaders and the health facilities at the end of the month, where they will sit down together, harmonize their data, and the community people will be referring the newborns to health facilities to access the services. In addition, other programs like the new incentive program, where they have the demand side aspect, where they sensitize the caregivers on the importance and the timing for immunization. We have other partners like UNICEF. They have their own community volunteers that go house to house to sensitize caregivers on the importance of routine immunization. In addition to other demand generation activities that we are doing, like using the other media, like the jingles, airing of jingles, the social media, where we are sending the importance of immunization. So these are some of the few strategies that we have been using to create demand for the immunization. But we have seen how the conditional cash transfers has actually helped improving. Though we have been using all these strategies for years, like what Dr. Yusuf has said, over the 10 years it has worked in Katsina specifically, and we have seen how our coverages are, and it's like we are still where we were before, but with the improved coordination and some of the new strategies that were put in place, we have started to see some improvement in the demand for the immunization and other PHC services. Thank you.
Thank you, Dr. Kabir. And Yusuf, so looking across other contexts and countries, how would you think about this as an equity strategy in other places as well?
Yeah, so the Gavi 5.0 strategy has a huge component around that. So globally, what we've realized is that we're still missing lots and lots of kids. And it's a function of the weak system and also equity issues. So in the new strategy, which may be launched sometime soon, it has a huge component around that. And there is a specific strategy around zero dose. Let's go after every baby, wherever that baby is. So that zero dose strategy, if well implemented, will be the game changer, because it will address the issues of weak system and also address those equity concerns. On gender, there is also a huge conversations happening around how to look at the whole gender dimension of immunization service delivery. And Gavi is giving a serious attention to this. And for us in the foundation, one major driving motive for our work is the equity agenda. We are passionate about that, and we are putting a lot of resources around that. While we support Gavi, internally we also do some catalytic grant making to really push that equity agenda to the last mile. And we are we've really been working with other partners around to really see how we could put that at the next level. But for the demand side, one of the things we also noted around demand is this traditional approach to demand creation. And so one of the discussion is to say, can we rethink demand creation? Can we rethink demand creation within the context of human-centered design so that you do it within the context of the caregiver and the baby? And how do you now create demand with a focus to ensure that you change mindsets, you break barriers, and then ensure that babies actually get vaccinated? And in one of our efforts, we've even created a community of practice in Nigeria where different partners working on demand side are brought together to really interface with other global partners who are trying to rethink the demand strategy, especially within the context of human-centered design. And therefore, with this, we feel that there will be a significant shift in behavioral change. And so if we break the barriers, we also have to change behaviors. And if we change behaviors, we also have to sustain them. And so this requires working across the continuum to really change those mindsets. But in conclusion, both Gavi, the Gates Foundation, and other partners are really around demand, but also innovations around demand. And some of the work you have done also around demand, around incentivizing demand, is one of those key tools that we found to be quite effective in creating and sustaining demand.
Excellent. Thanks, Yusuf. I would say on this sustainability issue, first, when you immunize a child, there's a cohort effect. So even if you are just gaining in the period of a program on-time immunization, there are durable benefits to that early immunization. So that's one way to think about sustainability. But I would also say there is some evidence from the Latin American cash transfer programs, particularly a program in Nicaragua, that showed that even the program operated, this was more of a conditional cash transfer against a set of primary health care utilization measures. But once families sort of saw the benefit of it, even though the transfer was discontinued about 5 years later, the utilization gains were sustained for the families in those communities because they were sort of accustomed to using primary health care more regularly. But it's definitely an area that requires further discussion. But I would go back to the point that Buddy was making about the cost effectiveness of the intervention matters here. It's not cost saving as the actual, but if the immunization is actually cost saving, you can imagine that if we put these things together, it could be quite important to raise immunization coverage and sort of, especially in places where other kinds of norm setting or legal requirements for immunization are not enforceable or not able to be observed by many families just because of the level of poverty. But maybe I'll turn to you, Buddy, as you've also, I think, participated or been involved in some cash transfer impact evaluations more broadly in your previous role. But how do you think about the role of these kind of micro transfers versus broader programs that are focused on safety net, and like, could they be combined in some way? I mean, just to say, in sub-Saharan Africa, there have been a number of unconditional cash transfer programs. And one of the reasons why they ended up being unconditional programs was because, well, first, because the main goal was to support consumption. But second, because it was hard to verify conditionality. I think another part of the new incentives, All Babies Are Equal program that's interesting is that they were able to verify incentives at to verify compliance with conditions at a fairly low cost and in a way that was cost effective. So I'll turn to you, Buddy, sort of to reflect on that issue. Should we, looking at the scale up of these safety nets and cash transfers in general, either through NGOs or through government, which government obviously runs the big programs, I mean, is there a role for a microtransfer on top that is linked to immunization, especially given that coverage has fallen in so many countries?
Yeah, great question, and lots to unpack there. I'd like to also just comment on some of Yusuf's thoughtful remarks on sustainability. But first on how do these kinds of programs interact with social protection measures that governments are rolling out? I think, our read of the evidence and different programs that have been tried across the continent, but also in South Asia and elsewhere, is that, if you're really trying to improve a particular outcome, like immunizations or school attendance, a broad social protection cash transfer is unlikely to be the most efficient way to achieve those improvements. When we look at unconditional cash transfers, whether rolled out by governments or by private NGOs, I think there, seem to be solid programs in terms of improving consumption, as you said, of smoothing people's consumption during shocks. But if we look at the extent to which they're actually cost effective at improving things like primary healthcare uptake, especially of preventative measures like immunizations or education, it just doesn't seem particularly cost effective at improving those specific things. And so, to the extent that we need strategies around boosting immunization rates because they are very low in certain parts of Nigeria or in other countries, then I do think, more micro cash transfers that are targeted at incentivizing that specific behavior are necessary. And we shouldn't expect that, a government or NGO-led unconditional cash transfer or general social protection program is going to be as effective at improving that specific behavior. So, I think that's our current read on things. I think separately, on this whole question of sustainability, there's obviously different angles to it. There's the overall financing sustainability of having governments fund programs and help them scale. And then there's the intervention sustainability of like what happens to individuals if an incentives program gets phased out. Are they going to decrease their demand all of a sudden? I think this is a tricky issue and one where more research would be valuable. Just for context, in 2005, I worked on a study in Rajasthan, India, which was incentives for immunizations. It was shown to be very effective, but then scale up stopped because there wasn't sufficient buy-in to the idea that we should be incentivizing extremely low income or rural households to get vaccinated. And I think that, there's sometimes this instinct of like, well, we shouldn't be paying people to do things for their own good. And I think about that in two ways. One is there are kids dying of preventable diseases. And so what's the most cost-effective way to prevent those kids from dying? And our read of the evidence is that like, actually, this is incredibly cost-effective, even if you sustain these incentives forever. And so I think that's worth just putting in perspective is just how cost-effective the programs are and the urgency that we all feel at trying to address this issue. I think the second piece of the sustainability, if you really are concerned at some point of if this phases out, will households continue to want to get immunized and have that demand? One is the study that Amanda mentioned, which shows that actually gains are sustained. I think the other is just you see that there's potentially some more fundamental behavior change that's happening even from this study, right? So the positive spillovers to the non-incentivized immunizations also increased. And so, we don't have solid enough evidence to say definitively, but there's enough to suggest that actually, providing incentives for families living in really remote areas that have a high opportunity cost of their time is just like the right thing to do to give them a little bit of breathing space to, pay for the journey to the clinic, to pay for their time that otherwise could be going to generating income for their family. And so seeing it less as, we have to pay people to do things that are good for themselves and more that this is like a costly behavior for them. And from an equity lens, we should compensate them for their time to like do what's right for their kids because they are very strapped both on time and income. And so, I think that's another way that we think about immunization, and that by doing that, that increases other health seeking behavior. And so there's some indication that it is actually sticky beyond the program.
Thank you, Buddy. Very well said. Okay, so we're down to 4 minutes left. So I'm going to ask each of you, maybe starting with Shagun because he was kicked off his internet, to sort of reflect on what you've heard and, what is it that you think new incentives or to do next, or other funders, including government, and or messages to the world. So let's start with you, Shagun.
Thanks, Amanda. The quick question we should all ask ourselves is, why is coverage consistently low in that region, despite the humongous resources expended over the past few years? I have two probable answers, and these are literacy and poverty. The low coverages are directly linked to these overarching issues. And until they are resolved, it's going to be difficult to make a consistent impact. The study has shown very clearly that it is impactful. And it needs some consistent support, maybe for about 3 years. And also more important, government buy-in. Government can buy in if they incorporate it into their unified operational plan, which is done by the states and all the development partners. And there's an opportunity in the PHC fund. There's a 1% of consolidated fund of Nigeria that is dedicated to primary health care and health insurance. So I don't know if the incentives is up to it, maintain the tempo of the increase in coverage. And the same principle applies for all the other components of immunization. Vaccine supply has to be consistent. Human resources have to be consistently trained. Cold chain has to be consistently maintained, and so on and so forth. Thank you. Back to Amanda.
Thank you, Shagun. Those are very operational and relevant recommendations. Thank you. Now, Allison, your thoughts.
Sure. I know we're running low on time, so many great things have been said already. I'll just say that I know that New Incentives is thinking very deeply about many of these issues and is thinking about the role of data and evidence and answering them and guiding them as they continue to scale up, and then perhaps at some point think about what happens next. So I'll just say that I'm really excited to see New Incentives progress as an NGO operating in this space, but then also to see New Incentives and the Nigerian policymakers as well, who have been so committed to data and evidence, just continue to generate really important and valuable lessons in this space.
Thanks, Allison. Shaimo, Kabir?
All right, thank you. Just to say that we are very happy. At least we have seen an evidence-based findings that will guide policy and decision makers to plan for improving routine immunization. So we have New Incentive and other partners will continue to support the government of Nigeria with evidence-based data to guide routine immunization in Nigeria. Thank you.
Thank you, and thanks for all your work in this area. Yusuf?
Thank you, Amanda. And I think the point made by Shagun is apt around some of the major drivers of underperformance, literacy, poverty. But we also have to look at sometimes we should not put the blame on the caregiver. Those factors kind of put blames on the caregiver. But look at how weak the health system is. Look at how under-resourced the health system is. In some of the geographies, if you go, only salaries are being paid and there is no operational cost. So, and this brings the imperatives of actual government buy-in and ownership of the program. How do we, as we begin to look, to look at implementing some of these incentives, look at those levers? And one of those levers is how do we incentivize government to really fix some of those supply side barriers which we can't fund. How do we ensure that health facilities are ready to provide quality of care for a mother that brings a child, so that her experience is also another motivation and incentive for her to change her opinion about services. Over. So these are really quite critical, and so government buy-in is very critical, working with government institutions, and then also rallying partners around so that we have common vision around coverage, equity, gender issues.
Okay, thanks very much. I think it's never a question of blaming at all, but I think it's that what you raised earlier, which is sort of person-centered design. So what are the barriers to access care? And I think the other thing that's interesting about this intervention is that it was recording supply chain stockouts and things like that. So helping a little bit on the accountability on the supply side as well, which is an important factor to consider. I think we'll end with Sveta, because you said something so good at the end, buddy, that I'm going to count it as your final intervention. I hope that's okay. So Sveta, last comments on all of this, and we'll certainly bring all of you back, I hope, to discuss what's happening next. Go ahead.
Yeah, thanks a lot, everyone, for such a rich discussion. I think, two things that really stood out that we plan to think more about is going back to what Yusuf mentioned about those levers of change. A lot of what we do in communities related to awareness, related to the supply side, is about pinpointing what government and other partners are doing and seeing how we can use the incentives to augment those efforts. And so we hope to do that more and more to increase child health programs, other related complementary nutrition efforts, and all the other efforts that are going on at the community level. And then the second thing we're hoping to do is start to generate research around what are the potential long-term gains. And so something we constantly see, and is maybe a half complaint, half compliment, is the biggest thing we hear from clinics is, wow, utilization of other services are increasing. So we think this is a tool to help establish trust in the health system. And so we're really interested in looking at other research we can pursue to really understand what are other effects about healthcare utilization beyond the direct effects on immunization rates.
Okay, well, thank you so much to all of you for a great discussion. I appreciate you spending an hour and a half. We could talk, there's a broader discussion about what role with respect to COVID-19 vaccine, but we'll leave it for another day, because I think the focus here really is on childhood immunization, which is one of the most important and cost-effective interventions that we have in the global health armament. So thanks to all of you, and thanks to you in the audience for watching. Bye.